Lovely stuff. Good morning, good afternoon, and indeed good evening, ladies and gentlemen. My name is David Winterflood. I'm the director of No Man is an Island, Race to End HPV, and it's my pleasure to be your chair for this latest webinar in the Men, Cancer and HPV series brought to you by Global Action on Men's Health and No Man. And today we're discussing HPV prevention for gay, bisexual and men, including trans men who have sex with men, GBMSM. And we're very grateful to ILGA for their support of today's webinar. Can I have the next slide? We'll go to some brief housekeeping notes. Please do sign in using the chat, your name, your organization, and indeed country you're joining us from. We will have a Q&A at the end of all the presentations, so please do use that chat to ask questions, make comments, share thoughts, and yeah, it is due to be interactive, so we value your inputs. It is going to be recorded as well and posted on the GAMH website and YouTube channel. It's about an hour in total, so if you do have to dip off or indeed you find it that invigorating, you want to see it again or share with colleagues, you'll be able to do so. Let's move on to today's speakers. Real global tour that we're bringing to you today. We'll kick off with Dr. Peter Greenhouse, consultant in sexual health and menopause, joining us from France. We'll then celebrate the old alliance by moving from France to Scotland for a presentation from Doctors Janet Powell and Dr. Carol Gray Burton from the School of Health and Social Care, Edinburgh Napier University. From there, we will travel across the Atlantic to Dr. Joel Pileski at University of California at San Francisco, followed by Gachatan Sandhu, Director of Programs at ILGA, that's International Lesbian, Gay, Bisexual, Trans and Intersex Association over in Geneva. And last, but by no means least, following our Q&A, Dr. Tim Shand will bring us home in London with an update on GMEH NOMAN's work. So a world tour all from the comfort of your desk. Some brief acknowledgements before we get started. GMEH's work on men, cancer and HPV is supported by an unrestricted educational grant from MSD and by No Man is an Island, Race to End HPV. You've heard enough from me. Let's get started with our first presentation. Dr. Peter Greenhouse will focus on why MSM are at such risk of HPV infection and cancer and why gender-neutral vaccination is essential to protect them effectively. Peter, the floor is yours.
David, thank you very much, and a big thank you also to Peter Baker and Tim Shand for inviting me to kick off this very interesting webinar. Now, actually, you might think that a simple question like this is very straightforward to answer, and in fact, I could answer it in about 15 seconds, which is I'm going to do a little bit more than that. But I think we need to go into these reasons in some sort of detail and really understand why they're at much greater risk. And therefore, why the only really sensible solution is universal vaccination, what we might call gender equal vaccination. I know some people call it gender neutral. I prefer to call it gender equal. So these are my various different affiliations, BASH, ISIDOG, JUSTI and the EADV. But if we try to answer the question, the very first and the very simplest explanation is that most GBMSM have a much higher rate of partner change. And although I'm not going to show you these syphilis statistics, if you take a look at these statistics, you see something since HIV became treatable, you see a 10, 20, 30, 50-fold increase in the first few years. And then when the dating apps come along, the geolocation apps like Grindr and Growler, etc., you then see an exponential spread from that point. So there's really no doubt that they're at a much higher rate of partner change, and that's what determines their realistic risk. Also, the rectum, in terms of a site of infection, is much thinner skin than the skin of the vagina and the vulva, and of course much thinner skin than the penis. So the most vulnerable part that is most likely to get infected is the rectum, and also because it's hidden, it's least able to be detected. And that Joel is going to be talking about this big problem that anal cancer is much less predictable and therefore much less preventable. It's not like cervical cancer where you can screen for it with a relatively straightforward criteria. It's much more difficult to do, and that's Joel's specialty. And of course, you have many more, much larger proportion of people with immunocompromise, mostly HIV, but there are other forms of immunocompromise affecting all sexualities. And finally, because they're men, they're much less likely to be vaccinated in countries other than Australia and the UK. And of course, even in the UK, the vaccination program's only relatively recently started. And I just wanted to talk you through that because that's where I really fit into this. I was responsible with my colleague Colin O'Mahony for changing the original bivalent vaccination from 2008. We managed to change it in 2012 to a quadrivalent vaccination. This is still for girls only, with a catch up from 12 to 18. And finally, after some extra lobbying, largely led by Peter Baker and colleagues, we managed to get GBMSM vaccinated up to the age of 45 in sexual health clinics. So it was a sort of catch up and very hodgepodge sort of thing. It was hit and miss. Obviously, the people who were most at risk and most wanted to come in to get the vaccinations, by and large, were able to get them. But that was rather like shutting the stable door after the horse had bolted. Eventually, we got and once again, we're now out of the, my contribution was minuscule at this point. We finally got gender equal girls and boys vaccinated from the age of 12 in 2019. This then moved to the non-valent, the 9-valent vaccine in 22. And finally, we've just gone we've made it a lot more cost effective by just doing single vaccination at the age of 12, which apparently works very well. So why is it that GBSM are at higher risk of STIs generally? Well, everybody now, certainly ever since COVID, everybody knows the classic Anderson formula for the reproductive rate of infection. And if you really want any infection to spread widely, the faster you can change partners, the more likely it is to spread. And of course, it helps also if your transmission efficiency is high as well, particularly for the rectal mucosa being that much more fragile. So I thought I'd just give you one paper that puts it all into perspective. Really excellent meta-analysis with an enormous number of colleagues working on this paper, but just the one paper that's worth highlighting, with almost 30,000 men graded according to their HPV anal infection status and their sexuality and their age. So let's have a look at these anal HPV types, and you can see that the MSMs have much more than men who have sex with women. Even HIV negative MSM have more HPV. This is all the HR, that is high risk types, than the men who have sex with women. And if we look at just the HPV-16, it's very interesting. I just wanted to point out one thing here, is that in women with cervical cancer, 70% of all cervical cancer is HPV-16 related, whereas in the anal HPV types found here, it's very, very low. In fact, in not just MSWs, but MSMs as well. And so the conventional vaccine covering only HPV-16, HPV-18, and of course the types 6 and 11, which cause overt warts. That's going to miss an awful lot of disease in MSM, who have, by and large, a much larger number of different types of HPV in their system. And if you look at the 9-valent HPV types that are covered, nearly all of those types, compared to the total number of high-risk types, are covered by the non-valent vaccine. So the answer here is we need to get the non-valent vaccine in as soon as possible, and the timing is absolutely critical, because if you actually look at the status, HIV status and age and sexuality, then realistically nearly all the infection has been acquired by the age of 24. So anything you can get, any vaccine that you can get in sooner than that, and of course better still sooner than the 15 to 18 age group, you really do need to get the vaccine in straight away. So I thought I'd just give one simple take-home message, which is just to quote this excellent paper by Way et al. From the Lancet, that high anal HPV prevalence among young HIV positive and HIV negative MSM highlights the benefits of gender neutral, they call it gender neutral, I prefer to say gender equal, HPV vaccination before sexual activity, and it's much better than a catch-up vaccination. And a final point that they made, that HIV positive MSM are a priority for screening research. And once again, Joel will talk to you about that. So that's my take-home message, and I hope that's clear enough for you.
Thank you, Peter. Speaking with the clarity that I well remember from the campaign for gender-positive vaccination in the UK a decade ago. So thank you so much for that. And a reminder, ladies and gentlemen, please do input any questions that you might have for Peter at the end. We will have a Q&A at the end of all the presentations, so enter your questions into the chat. Would be helpful if you direct them to an individual in question, or if you want them asked them to the wider panel, you can also do so. We'll now turn to Doctors Jeanette Powell and Dr. Carol Gray Burton at Edinburgh Napier University, forgive me, who will present on their recent systematic review on GBMSM and HPV experiences and vaccination. So over to you.
Thanks, David. Right, thank you so much for inviting us. We're delighted to be able to present on our systematic review on how GBMSM experienced HPV and HPV vaccination. And this was recently published in a call on vaccination communication within human vaccines and immunotherapeutics. I'm Carol Gray Brunton, and I'm joined by my colleague Jeanette Powell. We just acknowledged our review members, Lewis Clark, whose PhD thesis this originated from, and Shona McPhail, as well as our subject expert librarians at the university. Next slide, please, Jeanette. So just to highlight, this comes from a broader vaccine confidence research program where we're looking at hard-to-reach groups on vaccination. When it comes to HPV vaccine, we've tended to focus on gender, sexual minority, cultural diversity, and also disability. And we've tended to take a qualitative approach and draw from critical theories. I've just flagged up some examples there of recent publications where we focused on young men and the HPV vaccine, just of interest in case you want to look at that in more detail. Next slide, please, Jeanette. So also as part of that program, we hosted a PhD studentship. Lewis Clark completed that in 2023, looking at GBMSM more specifically. And I've put the links up there in case you want to look at that in more detail. Next slide, please, Jeanette. Really just to give a bit of a background to the Scottish context and just picking up from some of the things Peter was mentioning, the HPV vaccine program in Scotland offers GBMSM up to age 45 years an opportunity to be vaccinated in sexual health clinics since July 2017. That's opportunistic. And now since 2019, like many countries who've moved to more inclusive vaccination programs, our boys are included alongside girls in the HPV vaccine program, although there are disparities in uptake. Now, when we came to be looking at the GBMSM and HPV vaccination literature, we noticed most focused on acceptability and completion rates, using quantitative research surveys and meta-analysis, and little was focused on GBMSM's experiences of HPV and the vaccination programs themselves, particularly post-implementation. Next slide, please, Jeanette. So our review question became, what are GBMSM's experiences and perceptions of HPV and HPV vaccination? Two related objectives there, looking at perceptions and experiences, as well as barriers and facilitators. We registered the protocol with Prospero, and in accordance with most reviews, reported these according to standardized procedures. Next slide, please, Jeanette. And here we were focused mostly on primary qualitative articles to look at those in-depth experiences. You can see some of our methods there. Next slide, and over to you, Jeanette.
Thanks, Carol. This slide's just shown a summary of the included studies that we used in the review. I won't talk to it all. And yes, Carol says we undertook a data synthesis, and we used thematic synthesis to undertake the review. And this was following a framework by Thomas and Harden, which included 3 stages of analysis. We found 2 analytical themes. The first analytical theme looking at the limited perceived relevancy of HPV among GBMSM, and these included 4 descriptive themes. Our second analytical theme we found was the role and influence of socio-cultural context and care experiences on HPV GBMSM vaccination. And this included 3 descriptive themes. I've put a slide up here just to show you, these are some quotes from the original articles that we got related to theme 1, which was looking at the limited perceived relevancy. Let you have a quick look at these. And then again, these are some quotes taken from the articles that we had in the review looking at theme 2. So the role and influence of socio-cultural context and care experiences on GBMSM. So what do these findings tell us? Well, it tells us the extent to which a gendered understanding of HPV plays a significant role in the perceptions and understanding of HPV and HPV vaccination for the GBMSM population. HPV infection and its association with cervical cancer was consistently reported as a dimension of the perceived low relevance of HPV for this GBMSM population, which does echo previous research that we found that suggests the feminization of HPV. So our findings highlight the effects and focus on cervical cancer messaging, which means that other significant cancers, which we've just heard about, that affect GBMSM in particular is obscured, including anal, penile cancers. So we're suggesting that actual future messaging should address the risks of anal and other cancers for the GBMSM population specifically to ensure that they don't miss out on HPV vaccination. Again, we also found this limited knowledge. The GBMSM population didn't actually have great knowledge of HPV, and this related to their lower perceived susceptibility to HPV and how it affected them. We also found that there was a real tension between healthcare provider and patient interaction. And this really was central, and it was noted by the GBMSM in the articles, who were unlikely to seek out the vaccines themselves, but they would actually take it if it was offered by a healthcare professional. There was also a significant finding related to sexual health disclosure and the role of stigma still, unfortunately, and the differences between sexual health clinics versus non-sexual health related settings. So stigma plays a big part still. So what does this mean for practice and policy? It does mean that as a cancer prevention message for GBMSM is obscured with regards to anal and penile cancers, and this awareness is needed in campaigns that are targeted to this particular population that highlights the severe disease outcomes for them specifically. We also suggest further training for healthcare providers with regards to GBMSM sexual health needs. As I said, there was this tension between sexual health services in clinics and primary care services for GBMSM population. We suggest that healthcare providers need to be more proactive in recommending the vaccine in various settings, given that GBMSM would not actively seek the vaccine, but would take it if it was recommended by a health professional. We would also recommend that actually GBMSM population and other sexual minority groups are core partners in further research, and they should be involved in co-producing resources and communication information that's relevant to them. We found that unfortunately the current communication efforts were ineffective and very much focused on cervical cancer. And there's also, there was clear messaging about cost and insurance coverage, about insurance coverage for GBMSM in particular, and there should be a focus on free of charge vaccines for this particular group. It's a quick rundown. We've also included some reference here, and I believe the slides are going to be made available.
They are indeed.
Thank you.
Thank you. That was wonderful, and I think well, first of all, forgive me, Carol Gray Brunton, not Burton, which I misspoke at the start, but incredibly insightful and speaking to, yes, this myth of HPV only being associated with cervical cancer, and as you said in that wonderful paper, which please do share in the chat if you can, around the feminization of the virus and its disease burden. So thank you so much for your presentations. Ladies and gentlemen, please do keep your questions coming into the chat. We'll go open up to the panel a little bit later on following our speakers. We now go across the pond to Professor Joel Palevsky, who will present on anal cancer screening. Joel, over to you.
Thank you so much. Thank you for the invitation to join you. Welcome to everybody on this webinar, and greetings from California. I'm going to share my slides. And I'm going to talk about the other very important part about anal cancer prevention in GBMSM, and that's secondary prevention for people who may or may not have already received the HPV vaccine. These are my disclosures. And as you've heard very nicely before from Peter, the risk of anal cancer is elevated, particularly in men who have sex with men who are living with HIV. There are several groups at particularly high risk of anal cancer. These are shown on this slide, but the three on the left are people living with HIV, women living with HIV, men who don't have sex with men who are living with HIV, and then MSM living with HIV. And what's really interesting here is that in each of these groups, that risk goes up very substantially as a function of age. In MSM living with HIV over the age of 60 years, they are by far the highest risk group, well over 100 per 100,000, so considerably higher than some of the highest rates of cervical cancer that we see practically anywhere in the world. In addition, another very important risk group are GBMSM who are not living with HIV. You see, once again, that increased risk as a function of age. So anal cancer is relatively rare in the general population, but in these groups it is not. And this is important because it gives us an idea of who we need to try and implement prevention programs in at the highest urgency. So the good news is we know a lot about anal cancer, primarily through its very strong similarity to cervical cancer. And many of you have seen this slide before, but we know that these cancers are preceded by this high-grade lesion. And in the cervix, we know that when you remove the cervical high-grade lesion, it very substantially reduces the risk of progression to cancer. So that's secondary prevention of cervical cancer. That's the pap smear screening system, followed by colposcopy, biopsy, and treatment. We know it works. And so given the similarities with the anus, the question we've had for years is, particularly in high-risk groups, can similar secondary prevention of anal cancer work? Because just like in the cervix, anal cancer is preceded by this high-grade lesion. To address that question, we performed a study called the ANCHOR study, Anal Cancer H-Cell Outcomes Research Study. And basically, we did a randomized controlled trial where we looked for biopsy-proven high-grade disease and then randomized people 50-50, all HIV positive, men, women, transgender people over the age of 35, treated half of them as best we could to remove the H-cell and follow the other half very carefully. We found a few very important things. One was, of the 10,723 people living with HIV who were screened, at baseline, 53% of the men had anal H-cell, 47% of the women, so these numbers are stunning. And then the highest risk group of people were transgender individuals who were 67% having anal HSIL. We also found 20 people with anal cancer at baseline who weren't aware of the fact that they had it, and so these individuals were immediately referred for treatment. The key study result, though, was that compared to the people who were treated, there was a higher rate of people who were monitored without treatment. We saw actually a 57% reduction in anal cancer in the treatment arm. Unfortunately, the progression rate was high in both arms. Of course, it was lower in the treatment arm, but in the monitoring arm, more than 400 per 100,000 people progressed every year from anal HSIL to cancer. That number was 173 in the treatment arm. Again, a good reduction, but I still think 173 is too high, and we still have more work to do. So the take-home points from the ANCHOR study were that treating anal HSIL can, in fact, prevent anal cancer in this very high-risk group. And based on those data, guidelines were put out by several societies. Two of them are mentioned here. One is the International Anal Neoplasia Society, and then the Department of Health and Human Services, CDC, in the US put out, I think, the first government guidelines for screening as standard of care in people living with HIV and EANS in other high-risk groups as well. Just want to say a few words about what that screening could look like. I want to emphasize we're still in the early stages, and some of the information we use to make those recommendations, I was one of the authors in the HHS guidelines and the EANS guidelines, involved a relatively limited amount of information for some elements of it. Others were very high level of evidence. But what we essentially recommended was that screening would be done by primary care providers, and starting with a digital anorectal exam to feel for anal bumps, hard masses that might indicate the presence of a prevalent cancer. So the DARE, as we call it, is really meant to be a cancer screening test, not an HSIL screening test. We recommend that screening happen in men who have sex with men living with HIV and transgender people living with HIV at the age of 35 years, and for all other people with HIV beginning at 45 years. And then, key point coming up here, if high-resolution anoscopy is available, then a swab should be inserted to do a combination of anal cytology and HPV testing. This is a slide from the HHS guidelines. I'm not going to go over it in detail. It's published. But the key point I want to bring to your attention is that fork in the road is HRA available. Doing high-resolution anoscopy is challenging. It takes a lot of time to learn to do it well. And there is a very limited number of people at this point who know how to do it. And so in many places where there are people who would benefit from screening, HRA is not yet available. We believe that we should not do further screening with cytology and HPV in these individuals since there's no ability to act on a positive result. But even if HRA is not available, we believe that everybody should get the digital anorectal exam. And if HR is not available and that DARE suggests the possibility of cancer, then those individuals get referred for standard proctoscopy. If, on the other hand, HRA is available, the specimen is collected first because you can't use lubricant. So the swab is done first, then the DARE is done. And based on the results of the DARE and the results of the cytology and HPV results, then there's a fairly detailed list of management actions based on those results. And again, I will let you take a look at these slides at your leisure. The International Anal Neoplasia Society went one step further in taking the data from ANCHOR and applying them to non-HIV groups because of the other high-risk groups. And so those include women with a history of vulvar acellular cancer, people who are immunosuppressed due to solid organ transplant, and men who have sex with men not living with HIV. And the recommendations are quite similar, in fact, to people living with HIV. So in summary, anal cancer incidence is unacceptably high, particularly in people with HIV, and particularly older MSM living with HIV. Anal cancer can be prevented, though again, we do have more work to do. The key part of the screening system will rely on primary care providers, and there's going to be a lot of work needed to educate themselves and to work with the community. And then I do, of course, want to emphasize the importance of primary prevention in all of this too. Very strongly support everything that was said before me. It's always better to prevent the initial HPV infection. We did a study of young MSM living with HIV at an average age of about 20 and found already at that age of 20 that about a third of them had anal HSIL. And so it really is critical to try and get as many people vaccinated as possible as early as possible. So I'm going to stop there. Thank you very much. Look forward to an interesting discussion.
Thank you, Joel. As ever, speaking to the core of this issue in terms of anal cancer screening, and as you say, incidence of anal cancer is unacceptably high, and we can prevent this suffering from happening in the first place. And really appreciate giving the shout out to Adair. Digital rectal exam, so important, because we know that this is just not prevalent in practice. So thank you for mentioning that. Please do keep your questions coming. For our panelists, they'll be sticking around. We will now go to Kachatan Sandhu, Director of Programs at ILGA, who will present on the perspectives of the GBMSM community on this critical issue. Kachatan, over to you.
Okay, hello, can you hear me?
Yeah, we can hear you and we can see your slides.
Okay, perfect. Okay, well, thank you very much and good morning and good afternoon to everyone. And my thanks to the organisers for inviting me to speak today. It's a pleasure to co-host this very important conversation. So just a little bit about ILGA. ILGA World is the International Lesbian, Gay, Bisexual and Trans and Intersex Association. And we are a member organization with over 2,000 member organizations from across 173 countries. And we work with our members to advance equality and dignity for LGBTI people everywhere. And HPV is a human rights and health equity issue, especially for gay, bisexual, trans and intersex men, as well as other men who have sex with men. This is a matter of life and death. HPV is the most commonly sexually transmitted infection worldwide, and we know it's not just linked to cervical cancer as well, but also to anal, penile, and other cancers as well, and all of which disproportionately affect our communities. So when we talk about ending HPV related diseases globally, we must ensure that we are including everyone, regardless of gender, sexuality, or where they live. Now, the first the areas that we have. So let me start speaking about the lived realities of our communities. As already mentioned, as we can see in global minority countries, especially from Europe or North America, the data already shows that in many countries, HPV continues to be framed only as a women's health issue, or what we've called the feminization of HPV. And that is something linked exclusively to cervical cancer and to girls' and women's bodies. As a consequence, as a result, many gay, bisexual, and trans men do not realize that they are at risk. This is particularly true, if not even exacerbated, in low and middle income economies or countries where health promotion materials rarely address men who have sex with men at all. Now, second is the fear and stigma. For many of our communities, walking into a clinic and asking for a vaccine that is associated with sexual activity can be fraught with fear. Fear of being outed, of facing hostility from health staff, or even violence. For trans and intersex men, the problem is often invisibility. They're simply not considered in the design of services. And then we have the issue of access. In many countries, boys and men are not included in national immunization schedules. Where vaccines are available private, they are all too often expensive. And this is particularly true for adolescent boys and young men who are not yet financially independent. oops, sorry, I've gone backwards. Criminalization. So these barriers are multiplied in contexts where same-sex intimacy is criminalized. To date, we know that 63 countries criminalize same-sex intimacy between two consenting adults. For gay, bisexual men and men who have sex with men, trans men, intersex men living in these countries, seeking healthcare can be dangerous. They risk exposure, arrest, or harassment simply for trying to protect their health. We hear from activists in our network that some people choose to forego care entirely rather than take that risk. So this is not just a health risk, it's a human rights issue. So decriminalization and protection of privacy in healthcare settings are critical if we want to reach everyone with HPV vaccination and screening. Okay, and the challenges in low to middle income countries. So most low and middle income countries still run girls only vaccination programs. This means that GBSM are often left unprotected, despite evidence that has already been presented by the other speakers, that the burden of HPV-related disease is high among them. This is also an issue of global inequity. Countries with the highest HPV-related cancer burdens are often the last to get universal vaccination. So we need global financing mechanisms such as Gavi to explicitly support gender-inclusive rollouts so that boys, men, and key populations are included from the start. In our work at ILGA World, our members in Africa, Asia, and Latin America, we often hear repeated calls for a rights-based approach to HPV prevention, one that recognizes the intersections of sexuality, gender identity, and access to care. Now, there's been a lot of conversations around the terminology around gender-neutral vaccination. And I want to say a word about this as well. Gender-neutral vaccination is a public health term that is meant to be inclusive, and it's certainly a crucial strategy. But the phrase can unintentionally erase the very populations we are trying to prioritize. If we're not careful, a neutral approach can often overlook those that are more at risk, including GBMSM and trans men and intersex men. At ILGA World, we prefer to use the term gender inclusive or gender equal, as was mentioned, or simply universal vaccination, coupled with explicit commitment to reach key populations. This is not just semantics, it's language that shapes policy priorities. So what do we need? Well, firstly, we need governments to commit to public-funded universal HPV vaccinations programs that include everyone, regardless of gender. We need health systems to collect inclusive data, train staff to provide stigma-free services, and develop outreach that explicitly includes GBMSM, trans men, and intersex men. And we need international partners to finance expansion in low and middle income countries so that access is not determined by where you live or how much you can pay. Especially now we've seen the impact as well of the rollback of funding and financing from key governments like the USA. And most importantly, we need civil society, including our own movement, to continue mobilizing, generating data, and centering the voices of those that are most effective. So in closing, HPV prevention is not just a medical intervention. It's a matter of dignity, equality, and justice. I look forward, and ILGA World looks forward to continue this conversation and to working with all of you to ensure that no one, not a single gay, bisexual, trans, or intersex man is left behind in our global effort to eliminate HPV-related diseases. Thank you.
Thank you very much, Gichat, and yeah, I think a sobering thought at times, your presentation there in terms of actually seeking healthcare can be dangerous for populations. I think that's something that we so often forget. So thank you for raising that vital point. I think that's a timely reminder to us all. Ladies and gentlemen, attendees, before we move on to the Q&A, we'd like to invite Samuel Garrigo from Hoimas, Kenya to say a few words. We'd already developed today's agenda when we first met Samuel, but we feel it's very important for them to share insights from their work on HPV prevention and anal health among GBMSM in sub-Saharan Africa. Samuel is joining us from Kenya. Samuel, if you could very briefly share some comments, some thoughts, some observations around today and your work with us. Over to you.
Good morning, good afternoon, good evening to everyone. Thank you so much for the opportunity. Can you hear me?
We can hear you loud and clear.
Okay, thank you so much. First of all, thank you so much for my co-presenters. I was just given an opportunity to give a few remarks, and I'm very happy for what they have presented. So I'm going to give a perspective from a community-based organizations. I'm here in Kenya. My name is Garrigo Samuel from Hoimas, Kenya, which is a community-led key population organization in Nairobi. We are currently working with key population with a focus on all typologies for key population. That includes gay, bisexual, and other men who have sex with men. And our focus is around HIV, prevention, HPV care, anal health care. So I'm just going to give perspective on what we are experiencing on the community, what is happening on the ground, the realities that we are facing as community-based organization that works specifically with a focus on HPV. So first, I'll give a small context. In Kenya, same-sex relationships is criminalized. So this most of the time create an environment where stigma, violence, and discrimination in healthcare are normalized under the pretext that our identities are illegal. So as a result of this, most GBMSMs are largely excluded from sexual health programs, including HPV vaccination, which only targets girls and women here in Kenya. My colleague Sanchu has just said about they forgo care. So the outcome of this are very devastating. So most of our community members, as a result of this, only access care when their conditions are advanced, with anal warts so severe and other anorectal conditions and HPV-related complications coming at advanced levels, which could have been prevented or treated earlier. So at Hoimas, which is a community-based organizations, we see these realities on a day-to-day basis. And these are preventable outcomes, which with policies and health systems that are very inclusive, providing HPV vaccination screening and awareness and care can be easily averted. So just to address this, what we did as a community-based led organizations, we came with a response, and one of the some of the response that we came around with is we normalized anal health care and HPV care among men and boys, and specifically GBMSMs, through community campaigns, creative spaces, and what we call peer-led dialogues and communications. So we integrated HPV and anal health clinics into our services, offering screening and follow-up alongside HIV and STI care. Another thing that we just did to advocate for this, because we are getting a lot of community members who are coming to our clinics, who are presenting at GBMSM's network-led clinics at advanced level. So we really wanted to understand what are some of these reasons that are making people presenting to the clinic at advanced level, not seeking care at a timely level, because most of them are coming at a stage that you can't do anything. The only thing that you can do is only surgical excisions, which is very costly. There's that healing, there's that psychological part of it because of the cosmetics that comes with it. So we advocated for guidelines change as referrals for advanced HPV-related conditions grew. So we convened healthcare workers who are working in GBMSM's led network clinics across Kenya. And some of the key findings that we got from this workshop was the absence of screening tools, and also SOPs for men, and also the limited and inadequate nature of the current national HCI treatment guidelines. So this drove our advocacy towards integration of HPV and anal health into Kenya's national STI and treatment guidelines. So we developed the first standard operating procedures for anal and genital examinations, surgical care, and also an expanded HPV intake screening tool that will take care for GBMSMs and also other key populations that are engaging in receptive anal intercourse. Our first presenter talks about the reasons why GBMSMs are at higher risk for HPV, and he talks about vulnerability to the rectum. So we engage policymakers, including the National Cancer Institute of Kenya and also the county governments, because in Kenya, healthcare is a devolved function. So there was need for us to develop to engage different county government just to press on gender-neutral HPV vaccination and also inclusive health policies. So we tried to come with a model just to cascade our model to other GBMSM-led clinics and facilities across Kenya, just to try and build a wider clinical capacity, because we are community-led organizations. So what we are seeing the GBMSMs presenting to our clinics daily with these complications. We had nothing to do. So one of the things, just to respond to this, we had to try to cascade our model to this other GBMSM-led organization. We also build a referral and a recovery program with stigma-free surgical partners, just ensuring that we are having what we call holistic care for those needing advanced treatment. Though some of these programs were stalled because of the lack of funding. Yes.
Thanks, Samuel. Can I just ask you, sorry to go, if you could just sum up in the next 30 seconds, if that's okay.
Yes. So just our call to action is just from the experiences that we have seen. This has shown that HPV prevention and treatment for GBMSM is not just a medical issue, but it's an issue of equity, inclusivity, and also justice. So we urgently advocate for gender-neutral HPV vaccination policies, whereby we need anal health fully integrated into sexual and reproductive health services for GBMSMs. Yes. Thank you.
Thank you. And I've included Sam Grigo's paper in the chat. There's a link there, which I urge people to read. It provides really deep insights into some of those issues that they've touched upon in that summary. So thank you so much for taking the time to join us, Grigo, Samuel. Dear attendees, we now open up to our Q&A. So if I could ask our panelists to rejoin me on the screen. And please do keep your questions coming through. The first one that we've had through to address to the panel. In many countries like Bangladesh, HPV prevention programs are still very limited for gay, bisexual, and trans men. From your US experience, what strategies could be adapted globally to ensure equitable HPV vaccination and awareness for gender diverse communities? I think, Joel, that might be addressed to you, but I would be interested to hear if our panelists want to join on that. But Joel, I'll throw to you first.
Yeah, actually, I responded to that question in the chat, David. I don't know if that's available to everybody. So if you want to move on to another question, or I could repeat what I said verbally.
Hopefully, I think it'd be worth repeating. I don't think that might have been missed just the way that those scroll through. So if you can provide a brief synopsis, Joel, I think that would be insightful.
Sure. Well, I'm not sure we have special insight from a US perspective, other than to say that I think the universal vaccination is by far the best approach, not the least because at the time when people should ideally be vaccinated before initiation of sexual activity, many people don't even know that they may be same-sex oriented. And so by far the best approach is to try and protect everybody. The cost issue is the real one here, I think. That's been one of the reasons why many countries have started with vaccinating only females. But I'm hopeful that single-dose vaccination is going to be an important step in that direction. It will make vaccination programs more affordable. But when all is said and done, for many countries, even single-dose vaccination is too expensive, and there will be an ongoing need, I think, for support of non-governmental entities such as Gavi and others. I think that's unavoidable. So I think we need to continue to push those groups and our own policymakers to continue to support vaccination in developing and other countries.
Thank you, Joel. Next question. Several of you have raised about the feminization of human papillomavirus. Can the panelists share what they think we should do to challenge rather this global narrative and approach?
If I may step in for one quick second. Sorry, Peter, I saw you just raised your many of you know that the International Papillomavirus Society runs a campaign called the International HPV Awareness Campaign. I happen to be the chair of it. But the whole purpose of that campaign is to remind everybody around the world, it's really a global campaign, that everybody is at risk of HPV. And the idea is to destigmatize it and, emphasize the fact that it's part of the landscape of living. Nobody's at fault for getting it, but everybody is potentially at risk. And so I think trying to get that message out through campaigns such as this is one step.
Yeah, it's partially a destigmatization message that you're actually putting it out to say anybody can get it. Everybody's got, in fact, almost everybody's got it anyway. And if provided your immune system will clear it, that's actually another message that should go out at the same time, is that smoking is the primary cofactor for HPV persistence. And in fact, the only HPV-related cancer that doesn't depend on smoking is throat. Although 50% of throat cancer is smoking related, but the other HPV throat cancers are just there's a different genetic pathway. Actually, I think that if you push the message a little bit more of the message about throat cancer, which actually affects 4 times more MSW than MSM, if you started to get ordinary heterosexual men worried about HPV, then you'd actually end up reaching everybody. Because I would have said that actually heterosexual men who have sex with women are probably the most ignorant group. They're much less aware of their own health. And if you suddenly did a really good campaign on extolling the virtues of vaccination and also the dangers, well, not the dangers of both the delights and the dangers of cunnilingus, it is actually quite ironic that it's MSW who are at the greatest risk of that. But we haven't mentioned that in this context. But that might be a way through. Get all men worried and concerned about HPV, not just specifically gay men. So, that would be a sort of a sexual orientation neutral campaign, or sexual orientation equal campaign.
I look forward to the billboards across the world that have the delights and dangers of cunnilingus written on them with your face next to them.
I've got a YouTube stand-up comedy version of that. If anybody's interested in my YouTube channel, you can have a look at that.
Thank you, Peter. Next question. Perhaps speaking to Jeanette, Carol, and Kachattan with this one. Is there any value in MSM target vaccination in the absence of universal or campaigns to vaccinate both males and females? I don't know if one of the 3 of you want to come in on that, or Peter or Joel at this point.
Well, we did it that's how we introduced it in the UK. It had some elements of success, but it was very hit and miss, and it depended, of course, on people having open access to sexual health clinics, which of course they do have in the UK. Not at all the situation that Gujram was talking about. We're very lucky in the UK, but that's not the way it is elsewhere.
Question. Sorry, Kachattan, you've unmuted, please.
Yeah, I think again, in the absence of universal vaccine, yes, MSM target vaccination has real value when universal vaccination isn't yet in place, but it should be, as Peter correctly mentioned, it should be a bridge strategy, not the end goal. Why is it valuable? Well, prevents disease in a high-risk group. So modeling and program data shows that offering, as the data has been shown, offering HPV vaccine to MSM through sexual health clinics can be meaningfully cut HPV infections, warts, and anal cancer risk. And it's cost-effective when compared to no vaccination in this group. There's also a feasible delivery channel. You know, the UK's national MSM programme demonstrates that a targeted offer can be implemented at scale, while a broader policy is debated. But there are clear limitations. It misses those who don't attend clinics or don't disclose. Many MSM, especially younger men outside urban centres, or they're in hostile legal social contexts that I've mentioned, can never be reached by clinic-based. Even myself, you know, I did not know that there was a HPV vaccination. I am born and raised in the UK. It was only recently, in a visit to a clinic that said, "Oh, you're eligible for this. Would you like it? And what are the benefits?" So now I've been vaccinated. There's no herd protection. There's selected programs that protect against the vaccinated individual, but don't build population level immunity. And there's this, of course, concerns around equity and stigma. Requiring someone to identify as MSN can deter uptake as well. So practical takeaways: if universal vaccination isn't available, run MSM targeted offered services via trusted services. Bundle with other touch points, offer HPV shots along with STI testing, with PrEP starts, refills, HIV care, hepatitis vaccination, etc. Same-day vaccination, minimal paperwork, and clear messaging that HPV affects all men, like Peter pointed out. And in fact, you know what? I have to say something, you know, quite political without my ILGA hat. Those people that were marching this Saturday in the UK that's saying that they want to protect England and protect English women and women in the UK. You know, perhaps use that same campaign. If you're going to do it, you know, get yourself vaccinated as well, because really, are you protecting all women? Monitor who you're missing, collect disaggregated privacy preserving data to see whether young MSM, trans men, migrant and rural populations are being missed. The key thing that I think Dr. Power Brunton showed, that there's a lack of data here on MSM men. And I think that's really key here, is collect that data. But one of the key challenges that you have is, how can you collect that data, especially when you're being criminalized, right? So at the heart of this is decriminalization, but we're not going to, the sad reality is that we're not going to reach, we're most likely to reach universal vaccination before we reach decriminalization, sadly. Okay. And that's the sad truth of that. So we need to go for universal vaccination, a bigger priority, because, you know, you're not going to have decriminalization, especially in those 63 countries, overnight. Currently, the rate of decriminalization is one country per year. It will take another 63 years for decriminalization to happen, if that happens. So I think the bottom line is, don't wait.
Yep. Good.
Thank you, Gichatun. And yeah, I think just to draw out one of your points there from some of the comments coming through the chat, I want to, before I throw to Tim, this very insightful comment from Nahareen, who's undertaken research in Bangladesh and Canada. And yeah, we know that it's really important to look at those scenarios in LMICs and high-income countries. And saying that they're saying that the Bangladesh government is not considering men to be inclusive to this program. The main reason, the lack of research and data on prevalence, and regardless of sexuality, we know that's an issue time and time again with the HPV burden in males. On the other hand, in Canada, where universal vaccination is available, lack of healthcare providers' recommendations is the main barrier for men to HPV vaccination. So some sobering thoughts, but it's also some wonderful insights from our panelists. Tim, if I could pass over to you to provide a summary of the GAMH NOMAN work going forward. Tim, you're just muted at the moment.
Great. I'll just be a couple of minutes. Thank you. I know that we're now at time. Thank you for all those fantastic contributions. I just want to wrap up by reminding people that the conversation doesn't end here. It's been such an insightful and rich discussion. So many people have joined us online. Thank you for that. Please, if you do nothing else, sign up to our newsletter if you haven't already, to continue to find out information about Global Action on Men's Health and NOMAN is an Ireland Race to End HPV's activities. You'll learn more about our future webinars. You'll continue to be able to support this ongoing campaign for gender-neutral vaccination, and we'll be able to keep in touch with you around all of the other activities, as well as forthcoming news and reports and research, including from many of the speakers today, around men, cancer and HPV. If you haven't already signed as an organisation our global call to action, which we launched last year at the World Cancer Congress, please do. We've now got over 65 organisations which have signed our global call for universal gender neutral vaccination, reflecting exactly the very need that we have touched on, you've all touched on in this webinar. Please do go to www.endhpvglobal.org. If you are at the IPVS International Papillomavirus Society Conference in October in Bangkok, please do join us at our session, get in touch, and we'll share more information about what we're doing to try and advance gender neutral vaccination in the Asia region. We have a forthcoming academic position statement. We are co-writing together with a range of eminent academics that we're really thrilled to be able to engage with. That will hopefully be published in a high impact journal, really to continue to make this case for the need to move beyond the feminization of HPV and really to highlight the importance of universal vaccination. So please do watch this space, and we'll be asking academics, including those of you who are speaking on this webinar and have contributed, to sign and endorse that statement. And we will, of course, continue this global advocacy that we have talked about and we've started in this conversation. And I was pleased Gurchatin called out in particular the challenge around Gavi and the current Gavi rules, which are reflected or are a reflection of, the World Health Organization prioritization of girls only as a primary target. And of course, what we want to include in what this conversation has made so clear is the importance of boys also being a primary target. And so do support us in that advocacy. Just a shout out to our next webinar. There was actually a question about other infections, and we hopefully on the 30th of October will have that very discussion, diving more deeply into the connections between HPV, male infertility, cardiovascular disease, emerging data around skin cancer and prostate cancer. Thanks to our endorsers. One of my glamorous assistants hopefully has put in the chat the evaluation code link, for this webinar. It is really important for us to hear from you. As always, there's so much to say, and we would love to hear more about what you thought, what else you think we should look at, and how do we continue to improve this discussion. So please do go to the link here or the QR code, and we will follow up this webinar with sharing these with you. But it will only take you a couple of minutes. There are only 6 questions. It was very rapid, and we greatly appreciate your engagement. And here's the report that underpins all of our work. So please do download it at this link on the QR code if you have not already. Thank you so much for all the insightful and rich inputs. Back to you quickly, David.
Thank you, Tim. Ladies and gentlemen, dear attendees, my thanks to you to attending. My thanks to our wonderful panelists. That's Dr. Peter Greenhouse, Dr. Jeanette Powell, and Dr. Carol Gray-Brunton, Dr. Joel Pileski, and Gurchatin Sandhu, and Dr. Tim Shand, and in the background, Peter Baker. So thank you everyone for joining us. I wish you a wonderful day. We look forward to hearing from you. We look forward to seeing you on the next one. Take care.
Bye.
Bye, everyone.
Everyone.